I guess you may be hoping that I'm going to tell you a very simple story about how to treat Achilles and patellar tendon and how they are very similar. But in fact, you will be disappointed because I'm going to actually share with you that these are very different tendon pathologies and very different tendon pains. And even in lower limb tendons, we have to actually consider very many things in our treatment strategies. So let's see, if we go through the perspective, if we compare Achilles to patellar tendon, are they structurally the same? Yes, they are. Are they morphologically the same? And the answer is no, because the Achilles can actually fail at the mid-tendon or at the emphasis that we talked about, the bone-tendon junction, and these require very different strategies. Are they mechanically and functionally similar? The answer is no, they're not, because we see very different capacities to store energy in our energy storage tendons compared to our positional tendons. So if we consider our Achilles tendon an energy storage tendon, a tibialis anterior tendon is a positional tendon, and it acts very differently from the Achilles tendon. Pathologically, they're the same because we see very much the same pathology in all our tendons and in the plantar fascia as well. And from a pain perspective, in the lower limb, they all appear to be similar. We don't have central sensitization, but in the upper limb, we do see evidence of changes within the brain associated with tendon pain. So that makes them a little bit different. And these differences reflect how we might approach our rehabilitation. And if we consider our Achilles and patellar tendon, they're actually very different springs. I like to think of my tendons when I'm rehabilitating them as a spring, and how am I going to get them to act like that again? And you can see that because of the different size and shape of these tendons, that this is very able to store a lot of load from a spring perspective. But this tendon, the patellar tendon, will be very resilient to loads, and I'll show you that is in fact the case. We do see differences in pathology and loads. We talked about this morning, that the Achilles in fact can have 3 very different loads. So we see pathology in the mid-tendon from our energy storage and release loads, but we also have compression loads in the mid-Achilles when we have a thickened plantaris that can sit right next to the Achilles. And when we dorsiflex our foot, we get compression between the plantaris and the actual Achilles tendon. So we can have energy storage overloads and we can have compression overloads. We talked this morning, feels like yesterday, that we see compression here in dorsiflexion of the tendon against the calcaneus, and we see changes in our tendon here, so we get compressive loads there. And Ebony just talked about friction loads, where if you go cycling and you do a lot of up and down with your foot, you will have tendon pain the next day, but it will be the peritendon that's giving you your problem because you've slid a lot of shearing loads between the tendon and the sheath next to it. In our patellar tendon, we only get insertional loads, so we don't get mid-tendon pathology, and we don't have any compression, and we don't have any friction loads. And the reason for this is a condition that develops at a very different age than the Achilles tendon. But taking this all into account, we actually have to think a lot about our loading strategies and how we're going to restore capacity because of all these different types of presentations. So why don't we see compression loads at the patellar tendon? There's some really interesting new stuff coming out about the patellar tendon. One of the key things is this appears to be a condition that develops in adolescence, and there's 2 studies that really provide us evidence of that. We did a study, a cross-sectional study as part of my PhD many years ago, where we looked at how many of our basketball athletes had pathology on imaging, and we found that in our adult population it was 29%, but in our adolescent population aged 14 to 18 it was 23%. So even our very young athletes had pathology within their tendon. There's a study by Carl Gislin. He did a prospective study. He looked at volleyball players coming into a volleyball school. And when they started at age 16, 22 of them had patellar tendon pathology. Then they jumped as part of their training for 3 years, and at the end of their schooling, when they were 19, only 4 more had developed it. So by far the majority of people had their patellar tendon pathology before they were 16. Now, this is really important from a perspective of understanding when a patient presents to you with patellar tendon in their mid-20s. Most of the time, you have to assume that that pathology has been there for a long time and they are presenting to you with pain as the first onset, not pathology as the first onset. There's quite a lot of interesting evidence, and I apologise for the graph, but it's a very interesting paper. This is Katja Heinemeyer's paper, and she looked at how much carbon-14 you had in your tendon and related it to how old you were when carbon-14 was high in the atmosphere, which was between the late 50s and the mid-60s, when there was a lot of nuclear testing. And the story is prolonged, but the bottom line is you lay down your collagen in your tendon up to the age of 17, and then you do not turn it over. So once you have your tendon collagen in the tendon, it stays there until you're in your 80s and 90s, unless you develop a pathology. So this is a really interesting thing. It really makes adolescence as an important part for the patellar tendon at least, and probably an important part of development for all of our tendons. So this has been also shown in horses. So the half-life of collagen in horses don't live quite that long, the half-life of collagen in horses is 200 years. So collagen's a very stable part of tendon structure, and you develop it in puberty. So once you start loading these tendons after puberty, you don't get any structural change. You get mechanical improvements in terms of properties, but actually you don't develop much new tendon tissue at all. So we were really interested in this. This is Elisa Rudavsky's work. We were looking at dancing, ballet dancers as they went through the ballet school from their pre-pubertal through to their post-pubertal years. And we wanted to look at how the tendon developed in that time. And what you can see from the sagittal view and the coronal view is that peripubertally you have not very much attachment of the tendon to the patella. As you get in your peripubertal years, you get more attachment, and then post-pubertally, you have a very good attachment of the tendon to the patella. Now, if you put excess load on this tendon before the tendon is fully attached to the patella, you develop pathology. So this appears to be in the period of time 1 to 2 years post-peak height velocity. So for girls, it might be 12 and 13. For boys, it's going to be 14, 15 years. And so what we found in 5 of our athletes, our dancing athletes, is we saw the pathology develop in this period of time. So this becomes a really important concept in terms of what can we do about this. It's really important from a perspective of our rehabilitation strategies that we can't probably change the pathology once they're post-pubertal. That's probably the pathology they're going to have for the rest of their life. That we may need to look at load management strategies in their pubertal years, but we're a little bit away from having the evidence for that. But the important thing from your perspective is we can change pain and function. And remember, we talked about this morning, it's not important about changing structure. So the patellar tendon is quite unique from the perspective of the age of onset of tendon pathology. So what about the Achilles? Well, this is a whole different beast. We don't see Achilles tendon pathology in young people. We see it in our 30s, 40s, 50s, right through to our 80s. We occasionally see it in young people with highly loaded tendons, sprinting, jumping athletes, but it often is in our 20s. It's not often at that age that we talked about in the patellar tendon. And one of the things is, even though we don't develop in puberty, we can develop it because of the load we place on our tendon through life. And this is another paper that I really like. This is Kujala's paper. And he looked at Finnish athletes who competed in the late 50s, early 60s, and he examined their Achilles tendons in the 90s. So 30 years after they'd been loading highly, he said, well, what's your Achilles tendon health like? And he compared the sprinting athletes to the rest of the Finnish Olympic team, and he found that the sprinting athletes were 15 times more likely to have an Achilles tendon rupture. And he looked at the middle distance runners, and he found that they were 30 times more likely than the rest of the Olympic team to have Achilles tendon pathology and tendon pain. So this suggests that we have load-induced changes, but maybe at different ages in our patellar tendon as it's maturing, in our Achilles tendon later on in life or as we're loading it. So we have very different perspectives from them. So what else might influence our patellar tendon? We talked about our pubertal differences. We see about half the rate of patellar tendinopathy in our girls, and it's probably because our girls' tendons mature earlier, and so they enter puberty earlier and they grow quicker earlier in puberty. So girls have a mature tendon probably around about 12 or 13, and they're not in a highly loaded environment, whereas boys mature their tendons probably around 15, 16, where they may be practicing and playing 10 times a week. Okay, so that's possibly why we see differences. We also know from that perspective that there's other things that influence our patellar tendon. So this study by Roald Barr and his son showed when they counted the number of jumps that were done in a volleyball month in a school in Norway, that the men jumped on average 11,000 times and the women jumped on average 3,000 times. So that's a load-based issue. And of course, there's anatomical differences from hip width and femoral rotation, that the women are much more prone to patellofemoral pain rather than patellar tendon pain. Now, this is really interesting because there are hormonal effects on tendons, and we see this again expressed mostly in the Achilles, that women seem to be protected by their estrogens or progesterones, or men are not helped by testosterone. Testosterone is responsible for a lot of the ills of the world, but I can't blame Achilles tendon pain and pathology on it yet, but I'd like to. What you can see is that men have this incidence of Achilles tendon rupture in their 30s or 40s. Women are much more sensible, don't really have a midlife crisis at all. But you see that women, once they hit puberty, once they hit menopause, oh boy, it's bad. Once they hit menopause, that they have this abrupt increase in Achilles tendon rupture. So estrogen is very important for tendons in women, and the loss of estrogen is very important for women. And so we are completing a study looking at hormone replacement therapy for women with gluteal tendon pathology. We should have the results in about 18 months' time, so stay tuned for that. So does imaging help us more in one tendon than the other? Imaging tells us about structure and pathology, but not about pain. Remember, you cannot image pain. And remember that if you have a patellar tendon pathology, it's probably been there since you're age 16. From an Achilles perspective, it may be helpful from a differential of peritendon versus tendon, but you should be able to do that clinically, and we don't have time in terms of how we go through that, but clinically it should be obvious that they have a peritendon problem. It can help with that plantaris issue we talked about, but even ultrasound and MR don't help us fully with that. You need some of that sophisticated UTC imaging to really tell us. So imaging in the patellar tendon really doesn't help us very much. The pathology has been there for a long time, and it doesn't mean that the tendon is the source of the pain. So it doesn't really help us differential diagnosis, because if you have an MR and it shows patellar tendon pathology and it shows a little bit of patellofemoral joint problems, you still don't know what the source of the pain is because you have pathology in both. So it doesn't help us very much. So you have to rely on your clinical skills. This is really important. Looking at how we diagnose tendon pain, we're not going to base it on imaging because we know that that imaging is not telling us about pain. Tenderness on palpation is not a diagnostic sign. What we find is that tendons are very sore. So in the knee, if you have osteoarthritis or patellofemoral joint pain, your patellar tendon is extremely sore to touch. So palpation soreness doesn't actually help us at all with our diagnosis. What we do know helps us is a very localised pain that doesn't spread with load, and that the pain increases as we increase the loading on the tendons. So we add our energy storage loads, our pain will gradually get worse. So they are the two things that will give us that idea. So our differential diagnosis around the patellar tendon is very much patellofemoral joint, occasionally plica or fat pad. In the Achilles tendon, Ebony talked about posterior ankle joint pain, medial tendons, and sometimes our local nerves and bursa. What about risk factors for these, and what do we see? You can see that most of these risk factors affect the Achilles much more than they affect the patellar tendon. This is a study by Peter Maliaris, and he looked at waist circumference and how thick the tendon was, and the red are the normal tendons and the green are the abnormal tendons. And he showed that if you had a waist circumference of 83 centimetres or less, you had a 15% chance of patellar tendon problems. If you had waist circumference of 83 centimetres or more, you had a 75% chance of patellar tendon problems. So this relates to our adipose tissue cytochromes, which appear to have an effect on our tendons. And here are two systematic reviews that we completed. The first one in diabetes, though there was 31 studies. It was a big systematic review. We saw that tendinopathy was more prevalent in people with diabetes, and this was mostly type 2 diabetes, not type 1. Diabetes was more prevalent in people with tendinopathy. This is clinically important. If you have someone who is obese and has tendon pain and it doesn't quite fit, you need to test them for undiagnosed type 2 diabetes or insulin resistance. And if you have diabetes, you're much likely to have had it for longer if you have tendinopathy. And of course, the tendons are thicker, so the pathology is worse. So diabetes is very bad for tendons. Here it is with cholesterol. This was a smaller systematic review, and it's pretty obvious that all your lipid profiles are worse if you have tendon pathology. So you have all the higher high-density lipoproteins, you have high triglycerides, lower high-density lipoproteins and higher total cholesterol. So cholesterol is bad for your tendon as well. That is nearly all in the Achilles tendon. What about genetics? The answer is yes in the Achilles and no in the patellar tendon. So this is Malcolm Collins' work. He looked at the COL5A1 gene and showed that if you had this T allele, you had much tighter packed collagen fibres and you were more vulnerable to tendon pathology. You're a better athlete, you can store more energy in your tendons, but you're more likely to have the pathology. But there's been a study by the Norwegians in the patellar tendon. They showed that you are not more vulnerable with this gene. That makes sense because you now know it's probably related to the load during adolescence that causes the pathology, not the genetic predisposition to it as it is in the Achilles. So that suddenly makes a whole heap of sense. So what are our key factors for rehabilitation for the patellar tendon? Get the diagnosis right with our localised load-dependent pain. In our desperate and dateless clinic, more than 50% of people we're sent to with patellar tendon pain do not have it. They have patellofemoral pain. So diagnosis is really important, and then we load them, and I'm going to show you how. In the Achilles, it can be any person, any age, right through from postmenopausal women to young male sprinters. So that makes it really tricky for us. So if we were going to apply our capacity slide through our strength, our energy storage and release, and looking at compression and endurance loads in the patellar tendon of a young jumping man, what we're going to see when they present is they have poor strength, they have muscle wasting, they have poor power, they have poor endurance, they hop like a duck. If we go back to this morning's lecture, they are not attractive to look at from an athletic perspective. Okay, we need to restore full function in these people because they want to play basketball. They want to have high strength and power and endurance. They want to jump. So we have to work very hard at restoring all of those things. If we look at the Achilles tendon in an older woman golfer, we will see exactly the same presentations in the calf: poor strength, poor endurance, muscle wasting, all sorts of things. And we need to restore her back to playing golf, and she needs endurance and she needs to be able to walk on different surfaces. But the answer is we don't need to get her up to these high energy storage loads. we can actually stop our rehabilitation at this point because she doesn't need much more than strength and strength endurance. And as Craig said this morning, there's no point rehabilitating an older woman golfer being able to hop and change direction. If she goes back to golf, she's just going to lose all that capacity anyway because you only keep what you use. So, considering how you approach this is really important. Other key factors are considering the peritendon, and we don't have a peritendon, or we don't have a sophisticated peritendon in the patellar tendon because we don't move the patellar tendon against the surrounding tissues, whereas in the Achilles we have sophisticated gliding membranes. So it's all about how much movement there is between the tendon and the surrounding structures. So Achilles, as we talked about, cycling and rowing, where you get a lot of movement without a lot of load, will give us peritendon issues. And you should be able to pick that up in your history. What did you do that was different? I went for a bike ride and I did a lot of new bike and I didn't have it set up very well, and now I've got horrible tendon pain. Well, you know that's not Achilles because they haven't done energy storage loads. Okay, so you can suspect that it might be our peritendon loads. What's our management? As Ebony talked about, we decrease movement. There's some medications that we use. Interestingly, we don't even know if this is an inflammatory condition. We talk about peritendinitis, but there's not a lot of evidence, in fact, that this is inflammatory based, but it's certainly irritable. Whether it's inflammatory or not, I don't know. A couple of other things. When we look at bilaterality, we don't often see people get tendon up and down the limb. So we don't see Achilles and patellar tendon coexist, but we see Achilles and Achilles, we see patellar tendon and patellar tendon. Okay, so we often, if you have imaging abnormality on one side, you'll often have pathology on the other side, so that about half the people we see will have bilateral pathology. Pain is sometimes bilateral, but there'll always be one precipitating tendon, one tendon that's much, much worse in terms of loading. But it can swap, because what happens if you have a painful tendon, you load one side and then you overload that and that becomes painful, so you shift your weight back onto the other side and you sort of have right Achilles, left Achilles, right Achilles, left Achilles. That's not an uncommon presentation for us. But really interestingly, be wary of the person that's had an injury on one side and present with Achilles, or mostly Achilles, pain on the other side. And what you will be is that they're very dysfunctional on their injured leg. So they might have had an ACL or they might have had a tibial fracture and they've lost a lot of strength, endurance and function on their affected leg, and they're putting all their pressure on their unaffected leg, and that's the one that gets the Achilles tendinopathy. So be wary of assuming that it's the leg that's sore that's actually the dysfunctional leg, because it can be the other side. What about the rest of the kinetic chain? It tends to be, you tend to get dysfunctional below the level of the tendon. So if you have a gluteal tendon problem, you lose quadriceps and calf strength. If you have a patellar tendon problem, you lose, you lose gluteal strength, quad strength, calf strength. If you have a patellar tendon, you lose quadriceps and calf strength. If you have an Achilles, you tend just to lose calf strength. So it tends to be below the level of the problem. In the patellar tendon, it's absolutely essential that you restore calf function, because the calf absorbs about 60% of your landing energy. So if you have poor calf function and you're continually landing from a jump and you lose your strength, what will happen is you put the load on the patellar tendon. And soleus is very important. As you can see, as you change direction, that it's the soleus that's doing a lot of tibial braking here. So soleus function is absolutely essential in a patellar tendon. So you must be restoring, doing a lot of seated calf raises. So in summary, what's the same or similar between tendons? That's an interesting diversion, but it's actually meant to say same or different. Okay, so similar things between them. The structure's not important. We're not going to peg ourselves on the imaging, that the pain is not linked to the pathology, that imaging is mostly unhelpful for us. They're both time-consuming to rehabilitate. We don't have any quick solutions. And we have really profound effects on performance. In the young athletes, they can't do their sport. In our older ladies, our gluteus medius tendon ladies, they often can't sleep, they can't shop, they can't go up and down stairs. They might not be able to perform, but they're very dysfunctional. What's different, we've talked about how they have a different age of development. We see much more men with patellar tendon problems, but the Achilles we see across both men and women, and the ages again, and the risk factors are very different. Okay, so risk factors affect the Achilles tendon much, much more than they affect the patellar tendon, and that's probably because of the accumulation of the age of development, how you use your patellar tendon as compared to how you use your Achilles tendon. Just to finish, to say this has been a wonderful conference. I'm so impressed with all of you. Mario, thank you for looking after us so elegantly in the last 2 days, and I'm looking forward to the rest of the presentations. Thank you so much. I better stop questions.